All right. On behalf of the programs in occupational therapy, I'd like to welcome all of you to the fall 2024 capstone presentation of our post-professional OTD program. I am Dr. Rochelle Mendonça, the director of this program. We have a wonderful doctoral student today, Kaitlin Lillywhite, who will be presenting her capstone journey and her final capstone project. To begin with, I'd first like to invite Dr. Dawn Nielsen, program director and professor of the programs in occupational therapy, to offer a few words.
Kaitlin, I just want to take a moment to congratulate you on reaching this very important milestone. So I'd like the faculty to just quickly give you a well-deserved round of applause. This is an
Thank you.
amazing achievement. And I'm so looking forward to hear about your work. I have no doubt that your work is going to inform future clinical practice. And so we're very excited to hear your project. So I want to turn this back over to Dr. Mendonça.
So we will now begin with Kaitlin Lillywhite's presentation, whose project is titled Increasing Multidisciplinary Inpatient Staff Knowledge, Competency, and Confidence in Applying Trauma-Informed Care with Brain Injury Populations. Before Kaitlin begins, I'm going to invite Dr. Pat Preeson to say a few words about Kaitlin.
Sure. Kaitlin Lillywhite is an occupational therapist dedicated to advancing evidence-based cognitive rehabilitation practices within the field of occupational therapy. She has earned her master's degree in occupational therapy from Midwestern University in Arizona and subsequently gained valuable experience across various adult care settings. Kaitlin completed a rigorous fellowship in neurology through the AOTA and MedStar National Rehabilitation Hospital in Washington, D.C. In addition to providing clinical care, she led research on high-amplitude movements in the inpatient stroke population and taught in a master's level OT program. Afterwards, as a lead clinician, she developed and led an entry-level doctoral residency program and held management and leadership roles in a large acute rehabilitation hospital. Kaitlin has now happily returned to neuroclinical practice, where she remains passionate about adult neurorehabilitation knowledge translation through the care continuum. Okay, Kaitlin.
Thank you.
All right. Thank you, Dr. Preeson. Sorry. Kaitlin, go ahead. You can take over now.
Okay. My capstone is titled Applying Trauma-Informed Care in Inpatient Brain Injury Settings. Psychological trauma is a response to an event or series of events that potentially create lasting harm and negative effects on a person's function and well-being. Traumatic events such as adverse childhood experiences, elder abuse, domestic violence, and hate crimes can take place during all stages of life. Childhood trauma is prevalent throughout the general population. Out of 10 identified adverse childhood experiences, or ACEs, more than half the adult population in the U.S. has a history of at least one ACE, and almost a quarter of adults have at least 3. These ACEs have been correlated to negative outcomes psychologically, cognitively, socially, physically, and medically. Some of the disorders and diseases that have been strongly correlated to childhood trauma include not only depression, anxiety, mood disorders, and suicide, but also cardiac, liver, and pulmonary diseases, metabolic disorders, infertility and pregnancy loss, lung cancer, and skeletal fractures. These diseases are all common reasons for emergency department visits and hospitalizations. Trauma-informed care, or TIC, is the framework of an organization's collective approach to anticipate and respond to the needs of clients with a history of trauma by creating a physically and emotionally safe culture and environment to facilitate healing and prevent re-traumatization. TIC bases its practices and approaches on the principles of safety, trustworthiness, choice, collaboration, peer support, and empowerment. Implementing TIC in inpatient healthcare settings can increase understanding of disease and promote resiliency within patients. Due to the prevalence of childhood and adulthood trauma, it is wise for healthcare providers to apply principles of TIC as a universal precaution, as all patients, regardless of trauma, would benefit from its principles. It is critical for healthcare providers to understand and exercise TIC within inpatient physical medicine settings. To explore the existing literature on this topic, I conducted a scoping review to understand the impact of TIC training on staff working in non-psychiatric adult inpatient hospital settings. After screening 2,439 studies from 3 databases, I included 3 articles in my review. Results from this review demonstrated consistent use of multidisciplinary TIC training rather than focusing on a single discipline. All studies utilized virtual training, although one study also included in-person trainings. Results consistently showed increased scores in staff attitudes, competency, and comfort in applying TIC. However, the frequency and durations of these trainings were highly variable. The small number of studies included in this review justify the need for further research in this topic. The results of this review have emphasized the choice for virtual, multidisciplinary training in inpatient settings and indicate training may be effective in increasing attitudes, competency, and comfort in applying TIC to inpatient populations. Dr. Priesen and I have submitted this scoping review to the Archives of Physical Medicine and Rehabilitation for publication. The need for additional literature and the results of the scoping review guided my capstone project. My purpose was to assess the effectiveness of TIC training of multidisciplinary inpatient healthcare staff regarding their knowledge, competency, and confidence in applying TIC to brain injury populations. The reason I wanted to narrow the topic to brain injury populations is because of the interesting interplay between psychological trauma and brain injuries. Research consistently reports a significant correlation between the history of childhood trauma and prevalence of brain injuries. Childhood trauma is consistently correlated to adulthood cardiovascular disease, diabetes, traumatic brain injuries, including concussions, and acquired brain injuries, including strokes. Conversely, surviving a brain injury may be a traumatic incident itself. In a meta-analysis, Tang et al. Reported that 17% of stroke survivors report having PTSD several months after the stroke. Those who had pre-existing trauma had even higher rates. Additionally, the experience of being in a hospital may trigger trauma symptoms due to threats of safety, medical and financial anxiety, lack of privacy, and frequent periods of isolation. I conducted a mixed methods pre and post quasi-experimental effectiveness study by providing a 2.5-hour virtual course on applying TIC to inpatient brain injury populations. Participants were multidisciplinary healthcare staff who either currently work or who have previously worked in inpatient settings. In this study, I measured participant knowledge, competence, and confidence, both quantitatively and qualitatively. Knowledge was measured with a set of 10 fact-based questions that were either author-developed or adapted from Bruce et al. Competency was measured on a 3-point Likert scale, where participants self-rated statements such as, "I feel competent in improving patient compliance and participation after initial refusals." Confidence was assessed using a 10-item standardized assessment, attitudes related to trauma-informed care, or the ARTIC 10. Pre- and post-test scores were analyzed using a paired t-test. Qualitatively, these outcomes were assessed using author-developed open-ended questions, which participants answered at the end of the course. A thematic analysis was completed using the 6 steps of Braun and Clark's approach. This photo is a screenshot of part of the course. Participants completed each step virtually on the platform Teachable. Knowledge was assessed quantitatively through 10 fact-based questions. From the pre to post test, participants significantly increased their scores, with the p-value being less than 0.001. When asked, participants appropriately identified contributing factors to trauma responses, such as social support, healthcare provider consistency and message, their ability to feel the provider is trustworthy, feeling physically and emotionally safe, and experiencing grief and loss. Qualitatively, participants most frequently identified improving communication as an actionable step in applying TIC, including actively listening to patients, increasing frequency of asking permission prior to taking an action, more thoroughly explaining processes and rationales, and ensuring complete confidentiality and privacy with sensitive conversations. One participant wrote, "It's difficult to ever have a conversation or interaction that's appropriate when there's a roommate in a shared space. We could consider taking the patient out of the room to a quiet hallway or other private area to have an opportunity for private goal setting and reflection." Competency was measured using a 3-point Likert scale to self-assess competency and skills. From the pre to post test, participants significantly improved their scores as P is equal to 0.048. Qualitatively, the most frequently noted of competence was understanding the impact of trauma across multiple domains: psychologically, socially, behaviorally, physically, and medically. Participants noted that developing the skill to have comfortable conversations about traumatic histories and having difficult conversations would help their competency. Participants also cited the need for collaboration with peers in real-time settings. One participant wrote, "I would like more opportunities to try to apply TIC principles to normal interactions with patients for myself and get feedback on what other ways those principles could be included." Confidence was measured using the Arctic 10. Pre and post test results were significantly improved, with P being less than 0.001. Qualitatively, participants reported that the TIC principles they were the most confident in was spread evenly across safety, collaboration, trustworthiness, and choice. One participant described applying the principle of choice as, "I will always have the patient decide to walk to the left or to the right out of their room." Empowerment was the principle that participants reported being the least comfortable in applying. One participant stated, "I feel like I do well with empowerment for physical tasks, but maybe not as much mentally." The results of this study align with results of similar studies, both the studies I identified in the scoping review, which focused on adult non-psychiatric inpatient settings, and also studies related to other settings such as emergency departments and pediatric inpatient hospitals. This strengthens the conclusion that TIC training may increase participants' understanding and ability to apply TIC in their clinical practice. Several elements of the results pointed to recommendations that are in line with formal and full scope TIC. In the qualitative section, multiple participants noted it would be helpful to have ongoing support and problem solving when applying TIC, including reflecting on real patient scenarios and collaborating with colleagues who also understand TIC. This fits into the true definition of TIC, a full organization's ability to participate and respond to the needs of their clients with a history of trauma. Organizations such as inpatient hospitals are recommended to pursue formal and intentional pathways to become trauma-informed. There are several limitations to this study, including the participant population. The small sample size may have contributed to less precise outcomes with limited ability to generalize findings. Because my professional network consists heavily of occupational therapists, most of the participants in this study were OTs. In future studies, having a more representative sample would be important. Another limitation is relying on self-reported data for outcome measures for the domains of confidence and competence. Self-reported evaluations may be susceptible to retest bias and social desirability bias. A third limitation is the partial use of standardized assessment. The Arctic 10 was utilized to assess participant confidence and has demonstrated very good to excellent internal consistency and strong retest reliability. However, the other two domains were measured without a standardized assessment and do not have known psychometric properties. These results reinforce findings from previous studies. They suggest that TIC training may increase knowledge, competency, and confidence in applying TIC to inpatient settings. Future research may benefit from establishing recommendations on the durations and frequencies of TIC trainings, as the current literature is variable in practice. It may also be beneficial to collect post-training data, including participant measures and patient experiences. The concentration of my capstone project was to provide healthcare professionals with advanced education and professional development. During the last few months, I have also had several opportunities to provide professional education through various conferences. The table on the slide shows 7 professional conferences I have attended, though the last 2 will take place in 2025. It also includes the format and the topic of my presentations. These presentations were primarily focused on TIC, though I was also able to teach a course on self-awareness, which was adapted from my presentation developed for a cognitive assessment and intervention course. The upper photo shows me at a state OT conference, and the bottom photo shows my session presentation sign. My capstone project not only made a difference in educating others and myself on TIC, but it also facilitated my growth and skills necessary for continuing to create professional development courses. After submitting a grant to the California Foundation for Occupational Therapy, which was developed for a grantsmanship course, I was awarded a research grant to continue these endeavors. With this award, I will be developing a series of continuing education courses for OTs on cognitive rehabilitation. Cognitive rehab is the topic that drove my desire to apply for and complete Columbia's doctoral program. I am enthusiastic to share this critical and often overlooked topic with OTs on a national scale. This slide shows a photo of me receiving the award at a state professional luncheon. It also contains a flyer that outlines the sources of my grant award. The last image is a screenshot of my award letter. I want to express profound appreciation for this doctoral experience and program. I had the privilege of already attending Columbia's graduation ceremony in May of this year and loved meeting faculty and colleagues in person. Although my years in Columbia's program were met with several significant challenges in both my personal and vocational life, I'm extremely appreciative of the understanding, support, and guidance of all my professors in helping me navigate my academic journey despite these challenges. I hope that through this presentation, it has been evident how all courses and professors have collectively contributed to my professional development and have prepared me for my next steps. I'm especially grateful to Dr. Preson, who has spent hours patiently providing me with mentorship and encouragement. I will always view my time at Columbia with immense appreciation and with reflection of profound professional growth. I would now like to take questions from the audience.
Thank you so much, Kaitlin. That was wonderful. I'm just first going to open it up to Dr. Preson as your mentor to start us off with questions.
Sure, Kaitlin, that was absolutely wonderful. Thank you so much. Very interesting and important work you've done. I want to ask you, what did you learn from your capstone that you will apply to the grant that you received? And good job on receiving that grant.
Thank you. It's exciting. I learned a lot about the methodology process and hope that I can make some adjustments going forward. So for example, with recruitment, I thought that things like flyers and attending conferences at a booth would be very successful with recruitment, but they actually were not. My best recruitments came from online platforms and also through personal contacts through various places where I've worked. So I'd like to capitalize on those going forward. And another process that I'd like to change is including the consent form as part of the online process with the course. Although it's a very small piece, it actually became a very big barrier to my process getting participants.
Great, those sound like really good ideas. One more question. How has your involvement in this research changed your clinical practice?
Yes, it's been very interesting. I came into the program not knowing very much about trauma and the effects that it had, especially with physical medical populations. And so now there's a few things that I do. One, I try to screen my patients for symptoms of severe trauma. Right now, I'm working in home and community settings, and I've been very surprised with how many people do endorse nightmares coming home from the hospital or from whatever diagnosis they have. Another thing is that I try to educate people on this topic when it's appropriate. When pieces and parts of information come to light about their history of trauma, taking the time to delicately educate them on this topic and this correlation has been very empowering for people. And additionally, I've tried really hard to implement the pillars of trauma-informed care. Even though these pillars are not necessarily novel thoughts of being a caring, collaborative therapist, it's given me the depth to really dig when I'm having a patient who's having a hard time, to really figure out what options I have, and to how to make each of those principles meaningful for the patient.
Well, it sounds like they're lucky to have you. Thank you, Kaitlin.
Thank you.
Wonderful. Dr. Simon, I think you have a question.
Thank you so much, Kaitlin. As you know, I collaborate with Dr. Priesen on the trauma-informed care, and this has been a really important topic. So outside of working within psychiatric settings, because there is a lot that goes unspoken, I think, and assumed, and there are other reasons for it. But I'm just wondering from a two questions. One is like from a clinical perspective, what do you think are the keys for clinicians to pick up on and to understand it better? It could easily be misconstrued or could be perceived as a result of a brain injury or as a result of, a medical illness. But are there any triggers, I think, that you can sort of highlight a little bit, and then I'll follow up with another question.
Sure. I think it's really important for therapists to change their mindset to understand that behavior is an expression of need. And sometimes we get that more in brain injury settings because the neurological behavioral aspects can also overlap with the behavior that's arising from traumatic symptoms. But really understanding that something is causing the behavior and it's not a reflection on somebody's character or personality necessarily will really help a therapist be able to get to the root cause of what's going on and to work with that patient side by side through the healing process.
Yeah. And thank you. It's a tough call, right? When there's so many things going on and so many different presentations. My other question is more on the systemic, on the system and organization levels. Do you have any thoughts about how to help that change happen? An organization has to be committed to, but being that you worked in administration and you have both the clinical side and the administrative side, I'm wondering what your take is on how to facilitate that for an organization.
Yeah, I mean, I think it's getting buy-in from key players who can become invested and help spread the enthusiasm for it. In several of the conferences that I went to, I had people in the audience come up afterwards and express more interest in that side of it and want to help their coworkers develop this knowledge and also bring it more towards the administrative scale. Most of the information that's been published on this topic has been published within the last 5 years. So I think we're seeing the start of a lot of momentum. And so as more information comes to light and there's more understanding from a clinical perspective, I hope that the administrative side can follow suit pretty quickly, even if they're not immediately interested in developing some kind of system or program for it at the start.
Yeah, I think it's a good point. It's important for people to realize that just being perhaps an adult, like almost every experience very often that clients have within a medical or a hospital setting, or even in a doctor's office, like, right, like waiting for a diagnosis or anything like that can be so traumatic for people. Even in school, so I'm really glad that you highlighted those points about what it's like to be socially isolated, have no independence, and how traumatic it can be for people. And sometimes the little things mean a lot. So congratulations, great job. And I could see this just being the start of a lot more to come, and look forward to it becoming more widespread.
Thank you so much.
Topic.
Dr. Gillen?
Hello, Kaitlin.
Hi.
Good to see you. It's been a long time. I just want to say congratulations. I know you had your own personal stuff going on when you were in my class. I just want to say you did a great job today. And it was very, very interesting to listen to you.
Thank you. And thank you for your support during that time as well.
Yeah, I know it was a hard time. Yeah.
Any other questions, faculty? All right, Kaitlin, you did such an amazing job that no one has questions. So you're an awesome presenter. First of all, I want to say congratulations to you, Dr. Lillywhite. You are officially a doctor today. You did an amazing job. I speak for our program and all our faculty when we say we're really proud of all of the work you did, all of the accomplishments you demonstrated on this presentation. And we know that you're going to continue this work. You really have a gift in this area, and you should definitely use that gift. We look forward to hearing about you demonstrating some amazing accomplishments in the profession, and hopefully coming back to us to tell us about them, because we know you're going to do amazing things. I just want to open up the floor real quick to faculty to congratulate you and to celebrate with you.
Congratulations, Kaitlin. So very proud of you. Very, very long way from the first class that I remember you in. So really proud of you.
Thank you. It really has been such an enjoyable program. I had high hopes going in, but my expectations have been far exceeded. So thank you.
Congratulations, Dr. Lillywhite. Wonderful job. And people may be hearing more from her because she has made her training available to all of us and to the community for free. So I have the link. You can let me know when I can give that to you. And I think it's a wonderful training. You do not have to be working on a brain injury inpatient unit to benefit from her training. So thank you very much for your generosity in sharing that.
Yeah.
And congratulations. I hope you celebrate.
Thank you. I hope to be in contact with people in the future about topics related to the soon-to-be cognitive rehab courses. So that will be a big endeavor.
That's fantastic. Yes, absolutely. Keep in touch with us. I'm sure we'll be reaching out to you for several things. So congratulations, Kaitlin. Celebrate today. There are lots of congratulations in the chat as well. Go get some sleep, rest. You are done. You are officially done.
Okay. Thank you,
Okay.
everyone. And thank you for taking